Hi, my name is Austin Harris. I'm an internal medicine resident at the University of Kentucky. My case is about a 76-year-old gentleman that presented with 12 hours of chest tightness, dyspnea, and orthopnea. He had a past medical history significant for coronary artery disease and heart failure with an ejection fraction of around 20%. On arrival, his vitals were within normal limits and his physical exam was relatively benign, with no respiratory distress at rest, no crackles on lung exam. He did have some lower extremity edema but reported no increase from his baseline. His D-dimer on arrival was 3.5, and he had a CTPE protocol with no opacification of the left lower lobe pulmonary arterial branches consistent with PE, as you can see in picture A. He also had clotting or mixing artifact in the pulmonary artery and pulmonary trunk, which you can see in picture B. And he did get a follow-up TTE after his CT that was able to visualize the pulmonary arteries, and using color flow Doppler was able to rule out pulmonary embolism. So it was determined that his CTPE findings had actually been due to a low flow state resulting in lack of perfusion of contrast through his pulmonary vasculature, which is shown in picture C. So pulmonary embolism and heart failure are common problems encountered by physicians, and we know that as systolic function decreases, the risk of pulmonary embolism increases, making this distinction important. The diagnostic gold standard for PE is the CTPE protocol. However, there are some limitations to this study. The study relies on the timing of imaging following a bolus of contrast, and in patients with poor systolic function, particularly right ventricular systolic function, it can lead to increased time for contrast perfusion and potentially poor quality images or false positive tests. Another test that can be done is TTE. This allows for evaluation of things like right ventricular outflow tract changes as well as McConnell's sign, which are highly specific for PE. It can also allow you to assess volume status as well as left ventricular ejection fraction to help determine if these symptoms are largely due to volume overload versus pulmonary embolism. If it is determined to be pulmonary embolism, TTE allows for risk stratification by looking at right ventricular failure, right ventricular thrombus, and tricuspid insufficiency, which are all associated with poor outcomes. Some limitations to TTE include reader variability and ability to interpret these signs that I mentioned. All in all, there is no one perfect test for making this distinction between heart failure and pulmonary embolism. It takes the sum of all of your tests as well as the clinical presentation in order to make this differentiation. We did find some evidence that in patients with severe heart failure, talking with your radiologist about potentially adjusting the time between imaging and contrast administration can lead to better imaging. So going back to our case, our TTE read came back around the same time as our CT read, and it was determined that all of this patient's symptoms were due to heart failure. He did not get any heparin. He just got IV diuresis with improvement of his symptoms and was eventually discharged home. Thank you.